Good morning. I'll start with a case presentation. FP is a 60-year-old male, retired military, presents to his primary care doctor with a large, firm, non-painful mass in the posterior right thigh that he noticed about 2 months ago. He has no significant past medical history, no history of trauma to the region, no history of use of anticoagulants. Patient was referred to general surgery where an MRI was obtained. The MRI was evaluated by the general surgeon and interpreted as a hematoma. Patient was taken to the OR for evacuation of the hematoma. Transverse excision was used. Approximately 250 milliliters of hematoma and necrotic tissue were evacuated, and samples were sent to pathology. Post-operatively, the patient wound drained for over 2 weeks. Pathology returned as malignant fibrous histiocytoma, and the patient was referred to orthopedic oncology at that time. At time of initial presentation, the patient's wound remained open with moderate drainage. The patient was evaluated by the multidisciplinary team and prescribed 5 weeks of radiation, followed by a wide excision of the tumor bed. Plastic surgery was then involved for free flap reconstruction and skin grafting. I'll talk today about biopsy techniques of musculoskeletal tumors. We'll discuss the role of biopsy in the spectrum of evaluation of the patient who presents with an unknown mass. We'll begin with history and physical, as well as imaging. We'll then discuss different types of biopsies and their pros and cons. Excisional biopsy we'll talk about in a little bit more detail, and then finally we'll talk about the hazards of biopsy and the Duke experience with these complications. Beginning with history and physical, it can be difficult to distinguish between benign and malignant masses on exam. Benign tumors outnumber malignant ones that present to the clinic about 100 to 1, and history and exam can help provide clues to identify causes for concerns. In general, patient history can be nonspecific, so it's important to focus on certain details. Rate of growth is generally slower in benign tumors, where the size may be stable for years. Malignant masses often have faster growth rates, increasing in size over months or even weeks, and can exhibit variable growth rates over time. It's important to know that one must rule out a history of trauma in situations of a sudden appearance of masses or a sudden change in mass size. Also, depth within the soft tissue can be informative, as over 90% of benign masses are superficial, while 75% of malignant masses are deep within the soft tissue. Finally, size is also important, with 5 centimeters in diameter being a general cutoff for benign versus malignant lesions. However, while benign lesions are under 5 centimeters about 95% of the time, malignant lesions are a little bit more variable. On physical exam, lesions that are soft to the touch are most consistent with lipomas or hemangiomas. If on examination a pulsatile lesion is appreciated, that can suggest a vascular component such as an AVM or hemangioma. Fluctuant lesions suggest the presence of fluid such as synovial cyst or again hemangioma. Neurologic changes in relation to a mass suggest a primary neurogenic tumor, though mass effect from a non-neurogenic lesion can also cause this. And pain and tenderness palpation can suggest inflammation, and a history of trauma should again be discussed. We mentioned trauma a few times, but it is important to rule out traumatic causes for the lesion, but a history of trauma should not automatically stop further investigation. If one thinks a concerning mass is consistent with a hematoma, then you would expect to see ecchymosis present or develop within several days after the injury. Furthermore, 20 to 30% of patients who eventually receive a diagnosis of a soft tissue sarcoma will present with a history of trauma. So just because the diagnosis is there doesn't mean that you can stop evaluation for a malignant mass. In terms of imaging, plain films and CT can be very informative, but MRI has proven to be the workhorse for evaluation of extremity masses. MRI reveals the extent of the lesion within the bone and soft tissue, as well as the reaction of surrounding tissues to the mass. The inclusion of contrast can be helpful to determine blood supply to the mass and to provide further detail. MRI has high positive and negative predictive values with the ability to ascertain a specific diagnosis in 17 to 31% of cases with just imaging. Though 17 to 31% can be confidently identified, most masses will require further investigation beyond MRI for a definitive diagnosis. These masses often have a low signal on T1 MRI and a high signal on T2. Contrast may help, again, further distinguish characteristics of these masses, but they'll usually require a biopsy. There's 2 categories of biopsy employed in the evaluation of a musculoskeletal lesion. Percutaneous biopsies include fine needle and core needle biopsies, and open biopsies include both incisional and excisional biopsies. As the invasiveness of biopsy increases, the accuracy of the results also increase. Starting with fine needle biopsies, a fine needle biopsy can be described essentially as a soft tissue aspiration. It's performed percutaneously with a 24 gauge needle and has very little chance of disrupting the tumor bed. It's very cost effective since it requires no special equipment. Unfortunately, it's difficult to evaluate the histology of these aspirations since the structure of the sample tissue can't be evaluated. There's also a high potential for sampling error since the mass is not directly visualized. Use of fine needle biopsy also requires the presence of an experienced cytopathologist on staff, and that seems to be the primary limitation for its use, at least in the United States. Its accuracy is 70 to 75%, which is significantly lower than the other techniques that we'll discuss. Here's an example of a fine needle biopsy, or a fine needle aspiration. With the sample, one can perform immunohistochemistry, there we go, cytogenic analysis, flow cytometry, and electron microscopy. Again, due to lack of attainable tissue structure, evaluation of the histology is not very helpful. Moving on to core needle biopsy. It's the most widely accepted method for percutaneous biopsy of a questionable lesion. This procedure can be performed with minimal local anesthesia in the clinical setting. 15 gauge needle can be used, or like we do here at Duke, a specialized true cut needle. Core needle biopsy enjoys the benefits of the fine needle with the addition of the maintenance of tissue architecture. Diagnostic accuracy with that architecture in place increases to about 85%. In the case of deeper masses, image guidance can also be used, but oftentimes after reviewing the image in clinic, it can be done at bedside. Here we have a representative cartoon showing the true cut needle system. The needle pierces the skin as it enters the mass. And this is kind of fun. Yeah. The outer sheath is in advance, capturing the tissue sample while maintaining the architecture of the mass, and the needle is removed and the sample is collected. Here we have some representative clinical images. Scalpel is used to make a small incision at the area of the biopsy. True cut needle is then introduced into the mass via that incision, and the mechanism is deployed, trapping the sample. Once several quality samples are obtained, pressure dressing is applied and the procedure is concluded. Now here we have a core needle biopsy under some light microscopy. The architecture, as you can see, is maintained, allowing histologic examination of the sample. So technical pearls. Reviewing the available imaging, like I discussed before, biopsy is performed is important. This allows you to know the boundaries of the compartment that the lesion sits in that you're biopsying, and also prevent contamination. Allows you to see if there's any pertinent neurovascular structures nearby that need to be taken into account. A small wheel of anesthetic is injected into the skin only. That's all that's really needed. And it's important not to perform multiple biopsy incisions. Multiple passes are okay, but the goal is to do it through one skin puncture. Biopsy tract is considered contaminated after its use, and the plan needs to be that the biopsy tract is resected in block at the time of the definitive procedure. So the place where you biopsy needs to be planned, and you need to have a general idea of where your incision might be if it comes to excision of the mass. In terms of open biopsy, incisional or excisional are the two types that we'll discuss. This represents the gold standard currently, with accuracy rates approaching about 100%. As with percutaneous biopsies, imaging must be reviewed to ensure appropriate location and to avoid any necrotic areas. At the time of open biopsy, frozen sections are usually obtained during the procedure to confirm adequate tissue has been gathered. Disadvantages for this are mainly associated with the increased wound complications, as the wounds are usually larger than what you'll see with the core needle biopsy, as well as the associated cost of OR time. Here's a quick slide comparing the accuracy and the cost of core needle versus open. As discussed, accuracy of the open biopsy is increased in comparison to core needle, but so is cost, and significantly so. The final decision is made by the treating surgeon as to the best balance of accuracy and cost to the patient in the hospital system. On to the technical pearls. The goal, of course, is to obtain adequate tissue. That's why you're there, so confirm with the pathologist via frozen sections that you've done that. The goal at this point in the incisional biopsy is to not remove the mass, but to obtain enough tissue to diagnose it and then plan for a later surgery if necessary. Longitudinal incisions only should be used for better healing. If there are any drains placed at the time of the biopsy, they need to be in line with the incision, and avoid any areas of skin creases or skin tinting, especially if there's plans for chemo or x-ray therapy after the biopsy. And do not cross-contaminate the compartments, and then achieve meticulous hemostasis. That's important for why we'll discuss in a moment. So in terms of some examples of what not to do, we can see here in this clinical photograph that the surgeon has performed a transverse incision, as well as placing the drain, which is the arrow on the left, out of line with that incision. returning to our case report, we can see a relatively large transverse incision that has failed to heal several weeks after surgery. Here's a picture of an appropriate technique. The biopsy incision was made longitudinally, as we can see there, and now that the patient has returned to the OR for excision of the tumor, the biopsy incision has been remarked with plans to remove the previous scar and block during the second procedure. Here's why meticulous hemostasis is important. This patient's status post an incisional biopsy marked by the red arrow there. In a case where meticulous hemostasis was not obtained, the bleeding at the surgical site post-op has caused hematomas to develop along the thigh to the level of the knee. The hematoma for this patient must be considered contaminated, meaning the cells of the lesion possibly spread along the entire extremity. Moving on to excisional biopsy, this is a second open technique where the tumor is removed completely without a prior incisional biopsy. The advantage of an excisional biopsy is one surgery completes operative treatment and no further surgery is necessary. The risk of this approach is leaving behind residual tumor. In fact, 35% of unplanned sarcoma excisions have residual tumor left after surgery, leading to a second surgery. So it's very important to plan and know that if you're planning on using one surgery, to kind of know what you're dealing with. Indiscriminate use of this technique can lead to increased morbidity, mostly associated with the returning to the operating room and repeat excisions. With this in mind, excisional biopsies are best employed when the surgeon is 100% sure of the diagnosis. Excisional biopsy is also reasonable when its use won't compromise outcomes or increase morbidity, such as small, superficial, or benign lesions. Types of excision, you have intralesional, which is piecemeal, removing the mass piecemeal or curettage. Marginal is an in-block removal of the mass through the reactive zone of tissue surrounding the mass's borders. A wide excision is an in-block removal, including that reactive zone, with a cuff of normal tissue around it. Wide contaminated is the same as a wide excision, but there's been spillage or violation of that border with the contents of the tumor. And then a radical is an in-block removal of the entire bone or the compartment. Here we see some representative images of the various types of excision, increasing in degree of excision from intralesional to radical. Moving on to the complications of biopsy in general, they can include bleeding at the surgical site, subsequent infection after the biopsy, fracture of bony anatomy is involved, and a risk of obtaining a non-diagnostic tissue, which renders the procedure moot and requires a repeat attempt, and then, of course, delayed wound healing. Henry Mankin has studied extensively the hazards associated with biopsy of musculoskeletal tumors. Using questionnaires, Mankin interrogated the membership of the Musculoskeletal Tumor Society to determine if the incidence of complication associated with just the biopsy procedure. He also evaluated the effects of error in diagnosis on the patient's clinical course and if these problems occurred in greater frequency when the biopsy was performed at a referring center or at the treating center. Data from both the studies, the one in the 80s and the one in the 90s, is presented here. Notice that despite the separation in time, the rates of complications remain relatively constant. Mankin's analysis revealed that errors in complication associated with biopsy occurred 2 to 12 times more if the biopsy was performed at the referring institution. Furthermore, 27% of the biopsies performed at referring institutions were actually given the wrong diagnosis. The greater risk of complication occurred when there was no consideration of malignancy as a diagnosis before the biopsy was performed. And you can assume that this meant that proper technique and some of the clinical pros that we talked about before were not maintained. And finally, the risk increase if biopsy was performed by a surgeon not trained as an orthopedist. Here at Duke, data was collected back in the early 2000s on all the biopsies performed. 296 cases were evaluated and 47 complications were reported, including 7 needle biopsies with no imaging beforehand, 12 excisional biopsies with no imaging, all of which exhibited positive margins, 10 cases of excisional biopsies with imaging that exhibited positive margins, and 9 cases of transverse or oblique excisions. There's also 7 cases of post-op hematoma and 2 cases of IND performed for formation of an abscess. Doing the math, we can see that it resulted in about a 16% complication rate with biopsies during this time. This rate is similar to Mankin's results with an average complication rate of about 13% over both studies. Of the 47 problematic biopsies, non-orthopedic surgeons were roughly twice as likely to attempt a poorly planned biopsy as an orthopedic surgeon. So in summary, biopsies in all forms are an effective diagnostic tool for evaluating the unknown musculoskeletal mass. Appropriate imaging should be obtained and reviewed with meticulous planning before the procedure is performed, and that's anywhere from fine needle aspirate all the way up to an excisional biopsy. Biopsy is ideally treated as a first step in treatment of a limb salvage procedure and only used as a definitive treatment for benign or superficial lesions. And finally, if you're going to treat it, if you're not going to treat it, don't biopsy it. Menken's data shows us that the best thing to do is refer it to a sarcoma center for biopsy. Quick OIT question here. A 56-year-old man has had a slowly enlarging soft tissue mass in his left thigh for the past 6 months. Plain radiographs show only a soft tissue shadow with no mineralization or obvious bony involvement. Proton density MRI in the figures shows a coronal view and an axial view, respectively, of the thigh. At this time, management should include incisional biopsy. I'd like to thank the tumor team, Dr. Brigman and Dr. Eward. There's my references. I'll take any questions.
Hey, Patrick,
Yeah.
thanks for giving that. You covered a lot of the high points. I want to, since it's late, just mention one thing to
Yeah.
people leave. It's not true that rapidly growing equates with malignant and slow growing equates with benign, and that's a big pitfall. I think that's maybe some old data in there. And you know, that's really the biggest issue here. I don't think any of these disaster biopsies that we see, and I had a doozy in my clinic yesterday, come from people who think they're dealing with a sarcoma. The problem is really thinking you're dealing with something benign. And this idea that we can say, well, this feels like a lipoma, this is pulsatile, it's a hemangioma, that's really where we get in trouble. If it's bigger than 5 centimeters, if it's deep to fascia, if it's heterogeneous, it's bad.
It's great. It's a great talk. I just want to make one comment about Henry Menken's study, and even the study you have here about patients who referred here about complications from biopsies, is that you're only seeing the patients who get referred here. So the data is actually biased because you're seeing the patients who had a malignant tumor then got referred to a center. You're not seeing all the patients who had biopsy who had benign things who would never be referred. And just think about it, if there's 100 benign things for every malignant thing, and you take your 16% complication rate, and you say, well, maybe the other 99% of the patients who got biopsied didn't have a complication, so 1.6% complication rate, or even less, or 0.16 complication rate. So I do agree that if you think it's a sarcoma, you should send it, or at least call and speak to a sarcoma doctor. But I think that data is a bit over-exaggerated. The reason I think that's probably true is they did a study in Ontario using all the patients who had operated on for soft tissue sarcomas. You know, Bob Bell did that study. Maybe when you were there, actually. And they just did analysis of all the patients that were treated with soft tissue sarcomas across the province. There definitely was a worse outcome if it was treated in the community, but it wasn't like this huge difference that they're saying here. More like a 20% increase in complications. Overall, 20% change in what they were seeing compared to if it was treated in a community place or by a non-sarcoma surgeon versus a sarcoma surgeon. The differences weren't as big.
Okay. Thank you.
I have a quick question for Brian and Will. Is there education on the general surgery side? Because I feel like, at least going through residency and everything, we always hear about the disasters that come in with transverse incisions from a general surgeon. Is there any sort of crossover education where you go and you show them like these disaster cases of where a 3-inch transverse incision turns into something terrible for patients that maybe they remember?
I make a point of doing that case by case, but we probably should have a better outreach way of doing that.
Yeah, it is true that most of the problems that we have referred to us are from general surgeons. There is going to be, I just talked to Ted Pappas yesterday about an educational opportunity we're going to do this summer, where it's a CME event for lots of people, including general surgeons, where we'll talk about issues.
Because if it's a problem that they never know, that then you continue to run into the same problem.
Great.